Good afternoon, everybody. I hope you're all doing well. As you might have guessed, this presentation is going to be about Medicare. We're going to do an overview of the Medicare system. It's intended to provide you with a basic understanding of Medicare, its design and function. And we're going to look at specifically the process of entering the Medicare system, the various components that make up Medicare, how each of these components work individually and collectively to give you as comprehensive a healthcare platform as possible, and how to approach making choices in entering the Medicare system so that you can maximize the accessibility of healthcare coverage. So let's get started. Medicare is a federal program. It's been around for almost 60 years now, and it was created back in the mid-1960s to guarantee that individuals that met the basic eligibility criteria for Medicare would have a health insurance platform that they could count on entering and utilizing at the point when they reach their eligibility criteria. Medicare is administered currently by the Centers for Medicare and Medicaid Service, which is an agency under the Federal Department of Health and Human Services. Although most individuals are going to intersect with Medicare initially through the Social Security Administration. The exception might be for individuals who work under the railroad retirement system. They would make their initial point of entry to enroll in Medicare first through the Railroad Retirement Board, and then ultimately be passed on to the Social Security system to complete the application. In either case, from now on, when I refer to Social Security Administration, I'm referring to it as the generic idea of the entry point for the Medicare system. And it's important because, at least in the initial point, you're going to be dealing with them quite a bit, and you're going to make sure that the way you're dealing with them is going to be the most efficient and timely in accomplishing your objectives. Medicare has been and probably will continue to be a fee-for-service program. And that means that when you go to a provider under the Medicare system, a doctor, hospital, some kind of healthcare service provider that agrees to accept the Medicare card, agrees to work with Medicare, they will not bill you directly for the amount they will be reimbursed by Medicare. Instead, they will submit a request for reimbursement, a bill, either to Medicare directly or to a private insurance entity under the Medicare system. That doesn't mean you're not going to pay anything. There's likely going to be some cost share. It's built into the system. It's been that way for the 60 years that Medicare has been around. There will be anticipated deductibles and copayments. Now, back when Medicare was created, it was assumed that those deductibles and copayments would be small enough, manageable enough by most individuals that they would be able to afford. That's changed. And the nature of that change has compelled individuals to rely not just on the platform of Medicare, but also private insurance that works to enhance the basic platform of Medicare. And we're going to look at that in terms of the components that you're going to utilize. Now, the other thing with Medicare, and the way you have Medicare in terms of, what do I show a doctor or a healthcare provider that is evidence that I have my Medicare? That's your red, white, and blue card. It is indicating not just your name, but also a special Medicare identification number that's unique to you, and the components that you're currently enrolled in and the date that enrollment started. If you rely on Medicare, specifically the Part A and the Part B of Medicare, as your primary coverage, you can go to any doctor, any hospital, any care provider in America that you are anticipating utilizing. And if they accept Medicare, then Medicare will provide a basis for paying them initially, and then the private insurance product will enhance that portion that Medicare doesn't pay. The key to that is that there is no network that represents Medicare coverage. You have the ability to go to any care provider anywhere in America As long as they agree to accept the Medicare card, and by the way, that would be any hospital in America, and that would be more than 95% of the physicians and healthcare provider service in America. So Medicare itself is a national system, and it is a system that represents the majority and the totality of the providers in America. And that's a significant value if you are looking to utilize healthcare services, not just within your local region, but nationally, or just to be able to find the provider that you want to use without worrying about, are they part of some network? Are they within the system that covers me? Entering Medicare is based on a criteria of age or other circumstance. It is not defined by economics the way other programs are.
Excuse me, Bill. Excuse me. We can't. We're not seeing your slides.
Oh, for heaven's sakes. Okay. Thank you. Can you see them now?
Yep, we're good.
Okay. All right. So, well, so far, I think pretty much the narrative was indicative, but I'm glad you caught this before we went too much deeper. So, as I was saying, for Medicare, let me back up one slide. For Medicare, entry point is based on either age or a specific set of circumstances. Age in this case, unlike Social Security benefits, is still 65. If you're a U.S. citizen or legal resident of the United States, you are entitled to enter the Medicare system upon reaching the age 65. About 25–30% of the people in Medicare are there under age 65, and their entry into Medicare is based on their being recognized by the Social Security Administration or by railroad retirement as being disabled. Now, typically, once the Social Security Administration recognizes your disability, there's a 24-month wait before you're automatically eligible to enter Medicare. Now, there's one condition that waives that 24 months. That's amyotrophic lateral sclerosis, Lou Gehrig's disease. If the Social Security Administration deems you to be disabled and that disability is ALS, you do not wait the 24 months to enter Medicare. There is an immediate entry into Medicare as soon as you start receiving disability payment. There's a third entry circumstance into Medicare. Individuals that are under 65, if they demonstrate to the Social Security Administration that they are end-stage renal, that is, that they are likely going to be utilizing kidney dialysis because their kidneys are no longer functioning, or at least to the level that it is independent of dialysis, and or those individuals are on a transplant list to receive a kidney replacement. For any of these circumstances, once the individual has demonstrated to the Social Security Administration either age, disability, or end-stage renal status, the entry allows them to pick up the component parts of Medicare, Part A and Part B, and the additional products that are going to enhance the Medicare. So those multiple parts and how they coordinate, how they work together, is probably the most perplexing and most essential part of the choices you're going to make as you enter, and to some degree later as you navigate through the system. So understanding what these parts are and how they work are essential to making those choices. So the governmental platform, the initial benefit parts that you're going to pick up is the Part A, which is a significant coverage for inpatient care, and Part B, which is a significant coverage for outpatient services. Neither of those, though, are going to be comprehensive, and it is likely that in addition to that, you're going to be adding private insurance products. These represent the platforms that you must establish first before you can add any of the other products to it. They're often referred to as original Medicare or the traditional Medicare. There are certain things that Medicare itself, Part A and Part B, are responsible for covering. This is a quick example of the list of type of services under Part A and Part B. You can read that yourself. What's more important is there certain things that Medicare A and B do not cover. They never have, they likely never will. Basic dental care, basic eye care, certainly long-term care. At some point, your medical care, especially inpatient, becomes redefined as no longer a medically based service, but it's now personal care service. It's just an arbitrary decision. It's not because there's a logic to it, other than the logic of economics. The Medicare system or the private insurance under Medicare no longer wants to cover those costs associated with a chronic care need that requires you to be inpatient in hospital for a prolonged period of time. There's a natural transition for individuals when they go into hospital. What's evolved over the past 60 years, rather than going into a hospital, staying there until the condition is resolved or not resolved, coming out vertically or horizontally, has evolved into at least a three-step process. The first step is going in to an acute care facility, a hospital, through an emergency room or through admission, being there as an inpatient until the condition or the circumstance is stable. And then typically within a matter of days being transferred to a next step, which is often a skilled nursing facility, a rehabilitative facility, or sent home if the individual is at the point where they can do that. In either case, they're now moved out of an inpatient status, which has an unlimited timeline to it, to an entity, and I'm talking about skilled nursing, which has a definite timeline, 100 days. If after 100 days you're still in that skilled nursing facility, rehab facility, it's going to be automatically redefined, or you're going to be transferred out to a long-term care facility. And when that happens, when you are now in a long-term care facility or transferred to one, Medicare, the entire Medicare system says the cost of being in that facility itself is no longer considered medical. It is now personal care. And Medicare does not pay for that cost. There may be medical services related, incidental to being in the long-term care facility. The facility itself and the basic care one receives, well, that's not under medical. It's under whatever source you have that you're going to cover out of your own pocket or by some other means. And this becomes an important factor for individuals that have chronic, continuous need care that goes well beyond just a few months. That transition from it being medical to non-medical becomes an economic crisis for individuals and a significant economic burden. And let me warn you about one other thing. The assumption that you have the full 100 days is a misconception. Very likely, you're going to transfer from an acute care facility, a hospital, to a skilled nursing facility, rehab, and your stay in that skilled nursing is going to be far less than 100 days. The skilled nursing facility will often indicate that because you're not improving or because you're not cooperating with the rehabilitative regimen, or likely simply you're not improving sufficient, that they're going to recategorize you now in a long-term care status or transfer you to a long-term care facility. And that often happens in just a few days, perhaps a week or two. Very few people get to maximize the 100 days of stay. And quite often it comes as quite a shock and a surprise that the individual is being transferred or recharacterized. And at that point, they have to scramble to figure out how they're going to pay now for the care in that institution. The basic platform components of Medicare, Part A and Part B, have themselves a premium cost. Now, Part A, typically for an individual entering the system, has a zero premium. And the reason is you've been paying and supporting the Medicare system during your working career. During that period of time while you were working, you were paying in to the Medicare system, specifically the Part A system of Medicare. There is a small tax that's taken out of your wages. If you're self-employed, you are self-administering that tax in what's called a self-employment tax. The paying of that tax each year generates a number of credits towards your Part A premium. Each year, if you are reporting income and paying taxes on that income to the Medicare system, you receive 4 credit quarters for that year times 10 years that you're working, you have your 40 quarter credits, and you are entitled to Medicare Part A at a zero premium. Individuals that have worked less than the 10 years necessary to accumulate the 40 quarters or started paying into the Medicare system at a later time in their life may not have the necessary 40 quarters, and they may have to pay a premium for Part A. Most of you that are listening now are likely going to have worked your 10 years at least, have paid in your Medicare taxes on those wages, and are entitled to a zero premium for your Part A. In fact, the likelihood of that is about 90+% of individuals in the Medicare system pay no premium on their Part A. That is not the case for Part B. Part B was always presumed, even though it's really not any longer, an elective part of the Medicare system. Part B has always had some premium amount based on your income, and the income that's used to determine what your premium amount is going to be for Medicare Part B is based not on your current income situation, but on the income situation from 2 years prior to that particular year that the calculation is made. So if you're entering Medicare, for example, in 2021, the Social Security is not going to look at your income now in this particular year. They're going to look 2 years back. So for 2021, they're going to look back to 2019. And what do they look at? They look at your federal tax return. The reason they do that is because they do not want to devote a great deal of resources and time and effort of staff to determine your snapshot right now. How much am I getting this year? What's my wealth in determining what that premium is going to be? So it's much easier for the Social Security Administration to ask the Internal Revenue Service to determine from 2 years ago what your wealth was based on your federal tax return. Or if you haven't filed a federal tax return, based on the documents that would generate your tax liability, W-2s and 1099s. Looking at that and looking specifically at your adjusted gross income, they're going to determine based on that wealth what your Medicare Part B premium is going to be for this current year. If they find that your income from 2 years ago was less than $88,000 based on a single return, or less than $176,000 based on a joint return, they're going to determine that your Medicare Part B is the base amount, $148.50. If, on the other hand, for that particular look back year, your income is in one of the higher bracket levels, the next 5 brackets all the way up to above $500,000 for a single person or $750,000 for a married couple. In addition to the base amount, the $148.50, there's going to be an IRMA, an income-related Medicare adjustment amount. And that adjustment amount eventually becomes actually larger than the base amount. And that is paid in tandem with the base $148. Now, the good news is it's reconciled. You can request from the Social Security Administration for reconsideration. Now, what they were looking for is if this 2 year ago event is in itself an anomaly. The years prior to that, you were way under that amount. And in the years after, the couple of years after, that you were definitely still way under that amount. Or that was alleged that you dropped down from, that up until that point, your income was pretty stably above $176,000, but it went down. And the proof is going to be what's going to be the determinant of whether they accept your explanation or not. The good news again is with an adequate explanation of this particular year that you're using is not a normal year, or it's certainly not going to be a continuing year. You have a good chance of convincing the Social Security Administration to reconsider and recalibrate your Part B premium for that particular year. The other thing to know is this happens each year. So it's not once they've defined your particular premium level, it's that way for the rest of your life. It's going to be re-examined year after year. So if down the road you have a particularly good year, 2 years later, it's going to reflect itself kind of like a pig working itself through a boa constrictor on, now I've got a larger amount that I have to either pay or have a reconsideration that this is a unique situation in this year. So anticipate that regardless of what that amount is, if you're going to be enrolled in Medicare, very likely your Part A will have a zero cost and your Part B will have at least a base amount that you're going to pay each month. And how you pay that depends on whether you are already enrolled in Social Security or whether this is something for Social Security purposes you're going to do a bit later after you enroll in Medicare. Now, normally when Medicare was created, it was assumed that you would enter Medicare at the same time you would be entering Social Security at age 65. And the logical source for the Part B premium was taking it out of your Social Security benefits. Most individuals now are postponing entering the Social Security benefit system until after they've turned 65. And for those individuals entering Medicare first, without having a source of automatic revenue that the Social Security Administration can use to satisfy Part B, you're going to have to sit down with them and negotiate how you're going to pay for those premiums until you finally do start collecting Social Security. You'll either be direct debited out of some type of savings or checking account, or you're going to pay for your Part B premium, usually on a quarterly basis, billed directly by Social Security. So the process of enrolling, how does one get into the Medicare system? How do you navigate through it? Well, it's going to happen one of two ways. Either it's going to be automatic or it's going to be by you taking the initiative of reaching out. It happens automatically if you are already collecting Social Security benefits. So if you are recognized as disabled by the Social Security Administration, which is the basis for you going into Medicare, or if you started your retirement Social Security before reaching age 65, it could happen. And at the point when you become eligible, and it's noted that you're already collecting Social Security, the Social Security Administration will automatically place you in Medicare without you taking any necessary steps. About 2 or 3 months before you reach that eligibility threshold, you will get in the mail a package. That package will be including your Medicare red, white, and blue card, which will already be made out to indicate your Part A and Part B are going into effect, and a letter saying, congratulations, this is what's going to happen, telling you that if you want your Medicare A and B, you don't have to do anything. It will automatically kick in. If you do not want Part B, you must reach out within a reasonable time before this goes into effect to let Social Security know that you choose to pass on that. And by the way, you cannot pass on Part A if you are already collecting Social Security benefits. You must take at least the Part A benefit. You can still pass on Part B for the time being. Part A is mandatory. The other way is you take the initiative. So these would be individuals who are not collecting Social Security at all, and they reach the eligibility for Medicare at age 65, and they actually do wish to enter the Medicare system. You have a 7-month period. This is called your initial enrollment period. It's the 3 months before the month you turn 65, the month you turn 65, and the 3 months after. So this is what it looks like schematically. So I'll use me as an example. I'm going to turn 65 this April. I'm going to turn 65 on April 17th. And my entry point then is April. That's my midpoint in the schematic. The 3 months before that, January, February, March, are the months I would reach out to the Social Security Administration to say, I want to enroll in Medicare. If I do that during those 3 months, then I expect on the first day of the month, I would turn 65, April 1st in this case. I would enter Medicare, Part A, Part B, and I would prepare to have all the private insurance products that I'm going to be utilizing also hit at the same time. Now, I could postpone that if I want to. I could reach out in the month I turned 65. I could reach out in the 3 months after that. I'd still be within my 7 months. I would not be penalized or delaying in that 4th, 5th, 6th, and 7th month. But obviously, I'm going to be delaying my entry by 1, 2, or even 3 months before I can go in. So the optimum time to do this, the best time if you want to enter as early as possible, would be the 3 months leading up to the month you turn 65. Let me point out something else, kind of as a pre-warning. Right now, because the Social Security Administration is working very much from home or very disjointedly and not in a more central location, to anticipate issues, to anticipate problems, my recommendation would be the earliest you can do the reach out to do this, the better, to anticipate giving it time to work itself through the system, and more importantly, to give time to catch any problems and correct them before you reach that point where you want your Medicare to go into effect. Now, normally there's three ways to do the application. Normally, you could, and this would have been a 30-second portion of the presentation under normal situations. I would say just go to your local Social Security office, meet with somebody across the counter, say, I want to enroll in Medicare. 30 minutes or less later, you walk out, whoa, that was easy. You could also call the Social Security Administration on their toll-free number and say, I'd rather do it this way. They probably wouldn't be thrilled doing it, but they'd do it. Or you could do it the way they wish you would do it, which is go online to their website, ssa.gov, do the drop-down portion for I want to enroll in Medicare, and it takes a minimum amount of effort and time. So the problem is you can't go into a Social Security office any longer. The offices are temporarily closed because of the pandemic. You can't truly reach out by phone. You can, but what they're going to tell you is, you know what, we're reserving our phone system for emergency, and you're not an emergency because you have a third option, which is simply go online, do this. And there's nothing inherently wrong with that, but just know that give yourself enough time to adequately do the application, submit it, and make sure it went through without much problem, and you're not catching any issues thereafter. So this is what it looks like. You're going to go to the ssa.gov site. Again, this is assuming you're doing this in the lead up time to turning age 65 within that 3-month period. You're going to select the apply for Medicare only, and it's going to take you about 15 minutes to complete the application. No big deal, easy peasy. You're going to submit it. You're going to get a notification that you've successfully submitted. Here's your confirmation number. Think of that as your tracking number in case you need to make reference. And they'll tell you you'll get verification of the application within about 2 to 4 weeks. Honestly, think about 4 to 6 weeks realistically. You'll get a letter. The letter will say, congratulations, your application has been processed and successfully approved. Your Medicare Part A and B will take place on the date you anticipated. You'll also receive your red, white, and blue card shortly thereafter that. And if you don't have Social Security benefits already, you're going to receive a third letter saying, by the way, how are you planning on paying for your Part B premium? All of those letters should be hitting within that 4 to 6 week period. And the importance of getting the Medicare card is the Medicare card is going to show you your unique ID number. And that ID number is going to be necessary to purchase private insurance products. Brokers, insurance companies will not do the enrollment application. They certainly won't complete the application until you can provide them your unique Medicare number. So this process has to be completed. You have to have, if not the card in your hand, at least knowledge of what the Medicare ID number is, or you won't be able to enroll in the private insurance products that's going to enhance Medicare Part A and Part B. Again, earlier is better. What if you want to delay enrollment? And I don't mean just for a few weeks or a month or two. What if you want to delay it for an extended period of time because you have an alternative? And usually when confronted by a person who's about to turn 65, it's going to be, can I delay enrollment into Medicare? Wrong question to ask, because I'll say, are you collecting Social Security? Well, no, not yet. Then yes, you can delay. As long as you're not getting Social Security benefits, you can postpone Part A and Part B forever. The question to ask, will I be penalized for delaying that entry? And again, are you collecting Social Security? No. Then you have the right to delay entry into Medicare, Part A and Part B, indefinitely, and face no penalty as long as you're covered by employer health benefit, a benefit provided while you're working or through your spouse if he or she is working. In that case, that acts as an alternative substitute for the requirement to be in the Medicare system. And until you give up that employer benefit, typically because you stop working, you are entitled to delay that enrollment indefinitely. And this is becoming the new norm. It used to be, even just a couple decades ago, that most individuals upon turning 65 were seeing Medicare as the next logical step. Currently, greater and greater numbers of individuals that are potentially eligible for Medicare are postponing because for whatever reason, they're choosing to work well past age 65. And typically the place that they work is providing them at least adequate health insurance coverage. And they're electing to use that instead of going into Medicare. Now, they don't have to use the employer coverage. They could elect rather to simply enroll in Medicare and disenroll from the employer benefit even while they're still working. But many individuals find that the employer benefit is adequate enough to get them through and less expensive than going into the Medicare system. One warning, though. Other question I would ask that individual, it's not so much for penalty, but it's for effective utilization of healthcare. Not only you're not collecting Social Security, okay, you can postpone, but are you working for a large employer or a small employer? What's the difference? Well, first, the large employer is 20 or more employees. The small employer is less than 20 employees. If you work for a large employer, the presumption is that the employer's health benefit is the primary benefit. If you would pick up Medicare, that would be a secondary benefit, and it's not essential unless you can exclusively use your employer benefit. However, if you work for a small employer, anything less than 20 employees, then it's the reverse. The Medicare benefit is presumed to be primary, and the employee health benefit is presumed to be secondary. And even if you don't pick up Medicare A and B, what that health benefit through the employment could do is say, it's not our problem that you did or didn't pick up Medicare. We will automatically drop to a secondary status, which means we're only going to pay at most 20% of whatever services you get. And often you're not told this is about to happen in the year that you flip from less than 65 to 65. And you find out about it when you're notified by your healthcare provider that your claim for your hospital stay or doctor visit or whatever you're getting has been denied to the extent you thought it would be by your employer health benefit, and you contact them and they say that's because we're secondary status. Once you turn 65, it sucks that you didn't have Medicare, but not our problem. And it does become your problem. So beware if you are working for a small employer. Yes, you can postpone, but the quality of that benefit may not be something you want to rely on, certainly exclusively. If you work for a large employer, if you're covered by that large employer's health benefit, if you have not collected Social Security, then you can pass on the entire system. Even if you collect the Social Security, you can certainly pass on the Part B, and you can pass without impunity of penalty until that benefit is extinguished, either because you choose to or because you stop working and the benefit ends with your end of employment. Now, Medicare is relatively generous in giving you an extended period to work this out and get into the Medicare system. You have 8 months, but realistically, you do not want that gap of time. What normally you were seeking is a smooth and seamless transition from I'm ending my employer health benefit or it's coming to an end, whether I like it or not, to Medicare starts immediately. And within that period, you have special tasks to perform to make sure that transition is done. This is what enrolling in Medicare looks like if you are already past 65. You postponed enrolling in Medicare because you had employer coverage and it's now terminating. When should you start thinking about this? About 3 months at least before the benefit's going to terminate. Well, but that means I have to talk to my employer? Yeah, but I really don't want them to know. You better let them know because they're going to have to do something that's inherent to this application. So the longer you keep it a secret, the more risk you're going to screw up the transition because they've got to provide you with a document So the first thing you're going to say in this process of moving from one to the other is, look, employer, I'm going to be terminating within the next few months. Tell me when my health benefit will come to an end if I use this as my termination date. The employer will tell you, and you'll say, okay, there's something I need from you. I need a document. It's called a CMS L564. That's going to be informing the Social Security Administration, providing evidence that from the time you were 65, you had employer coverage. And if this also covered your spouse, the spouse is going to need their own document as well. So one for me, one for my wife. And at that point, I'm going to present that document to the Social Security Administration as proof that I was allowed to delay because I had employer coverage. Without that, it's going to create a problem and it could create a penalty. So I'm not just going to submit my application to pick up Medicare A and B, or we'll just use picking up Part B. I'm not going to submit just the CMS 40B, the application to enter Medicare. I'm going to have to attach to it the CMS L564. Now, remember, right now, you cannot do what I normally would have recommended. Just show up at the Social Security office with your L564 in hand. Say to the guy across the counter, I'd like to enroll in Medicare. Yeah, I'm 68 years old and yeah, I'm delayed, but I've got my L564 and my wife, she's got her L564. Let's get her done. And 30 minutes later, congratulations, you've completed your CMS 40B with the help of Jake from Social Security, and you've submitted your CMS L564 as your supporting evidence. Wow, that was easy, except Social Security is not open for business right now, so you're going to do it online. And therein lies a potential problem. So I go to socialsecurity.gov, I do the I want to enroll in Medicare, and I complete the CMS 40B, and it says, do you want to attach anything? Yeah, I'd like to attach the L564, except it's a paper. So here's what you do preemptively. You ask the employer to create the L564 in a PDF file for you. Submit the file to you. You attach it to the application you're doing online, and you submit it as one component. What's the alternative? Well, if he gives it to you in a paper form, if you can scan it and load it up onto your computer, same thing. The next best is not best. You're going to send it separately. You can mail it. Good luck. You could send it by fax. Double good luck. Because there is a very good likelihood now that that L564 will not end up on the same desk of the same entity that is doing the processing of your application, because they're going to be looking for that L564. And if they don't find it, if it's somewhere else, this is going to delay your application, possibly past the time you want it to go into effect. And you might not know, because once you submit it, it says successfully submitted. It doesn't care whether there's attachments or not. And you're thinking, oh, well, in 2 to 4 weeks, 4 to 6 weeks, and now it's 8 weeks, 10 weeks. Where the hell's my Medicare card? Let me call Social Security. What? You didn't even why? Because you didn't get the L564. But it doesn't matter. We don't have it. We don't have it. It don't count. Give yourself time. Find a way that you can combine those two. That increases your likelihood of success. What if the employer won't even give you an L564? It could happen. You can create your own, which you will attach, but you better verify why you aren't able to get the L564 from the employer, and you complete it yourself. And now you have to, guess what? Get ready to download a lot more information, the following kinds of documents to prove, since you can't get the employer to fill out the L564, that you in fact did have employer health coverage. Much easier to get the employer to do it if you can, much easier to attach it electronically if you can, because you're going to be either attaching those documents, faxing them, or mailing, which enhances the likelihood of a delay, if not downright failure in getting in. I'm not recommending that this is a bad thing in terms of delaying, but I'm recommending now, especially with the pandemic, it's adding increased risk of successfully accomplishing. So the earlier you start the process, the earlier you gather the information, the earlier you submit it, the greater the chances of having it successfully done or averting any problems that come about with not getting all the material to the right place at the right time. One of the things we do with our program is walk the client by the hand, step by step, to make sure their enrollment is complete and functional. And if there's a problem, we have a backdoor contact to the Social Security Administration that we can say, would you look at this person's file and tell us what's wrong, what we need to do to correct it, and we correct it. But even if you come to us, it's still going to be, we recommend the earlier the better, to give us more time to indicate if there's a problem and get it resolved. And if you cannot apply online at all, now it gets really likely there's going to be an issue, because you're going to have to get the forms by paper, which means, well, download them. If you could download them, you could do the application. No, you're going to get the Social Security Administration to send them, which means you've got to reach out and get them to listen. This is an emergency. Take my call, please. I need these forms mailed to me. Hope they arrive on time. Get them completed, mail them back, fax them, certify them. Oh my. Those are the people I would have told go to the local Social Security office, but again, we can't. So being able to do this online, finding a way to do this online, becomes imperative to a successful application for Medicare. If you fail to enroll within the time period allotted, if you do not get into Medicare during your initial enrollment, or if you fail to meet that 8-month, and some people actually manage to fail that, then you can still go into Medicare. But you're going in under general enrollment. You can enter in the first 3 months of each year. It will go into effect the following July 1st, and there will be a penalty. And that penalty is 10%, whatever the Part B premium is. That 10% accumulates for every 12 months that you could have, should have, would have, but didn't. So let's assume the individual is now enrolled in Medicare. They have their Part A, they have their Part B. Now what? Or at least they know they're going to have the Part A and Part B hitting at the right time. They're looking for the additional products that are going to help them defray the cost sharing that Medicare A and B imposes on the deductibles, the co-payments, the co-insurance. And they're going to be relying on private insurance to get them through that process. There are 3 ways that they're going to obtain private insurance. Either an employer, after they're done working, is going to provide them with not just an employer benefit, but a post-employment benefit, typically a retirement health benefit, but most individuals do not have access to this. A good example would be an individual that works for a school district. Public school system in the state of Pennsylvania will provide for each of its retiring employees a health benefit, either through a central program called the HOP system, or the individual school district will provide its own retirement health benefit. It will transition from the point they retire, even if they're less than 65, to the point when they do turn 65 and they're compelled to pick up some type of benefit that's coincidental with Medicare A and B. TRICARE is another example. While you were under 65, and if you were a full-time member of the military, you're accessible to that benefit. And once you turn eligible for Medicare, you're compelled to enroll in the Medicare A and B. Another system that works in tandem with Medicare A and B is Medicaid. Individuals that are dual eligible, eligible for Medicare and eligible for Medicaid, will use that as a system to give them comprehensive coverage. Most individuals, most likely you guys, are yourselves on your own going to go off into the marketplace and try to find private insurance that will enhance your Medicare Part A and Part B. Now, there's 3 types of products. The entire universe of Medicare can be assigned to one of these 3 categories. It could be a supplement to Medicare, typically referred to as a Medigap. In this case, you're using Medicare Part A and Part B as your primary coverage. You're supplementing it with a Medigap product, a private insurance product. In the second instance, you're enrolling in Part A and Part B, but you're replacing the utilization, the reliance on Part A and Part B with a Part C product, a Medicare Advantage product. And finally, you'll probably be getting a product that's devoted to covering the cost of your prescription medications. And that's referred to as a Part D plan. In that universe of those three categories of products, a Medigap, an Advantage plan, which is an HMO or PPO type product, and a Part D, the universe of how you organize them is divided into two. There's simply two ways that you're going to create a coverage strategy, and it's either going to be one or the other. The first option is you're enrolled in Medicare Part A and Part B, and you're going to supplement it with the Medigap. If you have this strategy, you have the expectation that through Medicare A and B, that's your primary coverage, you could go to any doctor or hospital in America and say, you take Medicare, right? And the expectation is every hospital in America, because they want to be accredited in their state, is going to say, of course we do. And every doctor that is going to want to work through that hospital system or be part of the network is going to say, of course we accept Medicare. It's good for you. That means here's my Medicare card. You'll take it. Yes. And here's my supplement. And if you take my Medicare card, by law, you must take any company's Medigap. Therefore, I have not just comprehensive coverage, I have universally accessible coverage throughout the entire United States. And this Medigap is so good, it can pay the entire balance of what Part A and Part B do not fully cover. Between Part A and Part B and this Medigap, I have, wherever I go, 100% coverage. The entire cost of all my Medicare coverage services are fully paid for. The fourth component is prescription drug coverage of Part D. That will never be as perfect as Medicare A, B, and a really kick-ass good Medigap. What's the alternative? Well, option two is I still have to enroll in Medicare A and B. I'm still going to pay the cost of being in Medicare A and B, but I'm not going to use Medicare A and B as my coverage. Instead, I'm going to enroll in an HMO, Health Maintenance Organization product, or PPO, Preferred Provider Organization product. What's the common characteristics of these? They're managed care. That means they have a network of providers. Certain doctors, hospitals, healthcare services that are under their umbrella are the ones you will go to if you expect that insurance to pay for it. Even the PPOs that say, oh, you can step out of network, but what they're going to pay towards that cost is so little. What you're left with is a cost share that's going to be preclusive of any high-end services. So for all intents and purposes, whether it's an HMO or a PPO, you are going to be facing a limitation of the providers that you can go to. And that limitation could change from year to year. Second, you're limited in the expectation of coverage. There will be cost sharing. Unlike Medicare A and B and a good Medigap, you will be paying co-payments, deductibles. You will be paying a significantly larger amount in cost sharing with option two than option one. And that depends on the quality of the product you buy. And three, there's no predictability. Every year, the product changes. Its coverage changes, its costs change, and you have to stay on top of it. So why would you do that? Why would you pick option two? You pick it because you're looking for a less expensive premium. Now, your Part A and Part B are going to be paid either way, so I'm not even going to talk about that. It's the comparison of the premium for Part C products versus the Medigap and the Part D. And typically, a Part C product, an HMO or PPO, is going to have a much lower premium, or potentially a much lower premium. And you're doing it in the immediate strategy of saving on the upfront, the premium amount, with the expectation that you're embracing limitation and the risk that if you get really, really sick and have really, really significant healthcare needs, you could be paying thousands, perhaps even more, tens of thousands of dollars in trying to acquire your healthcare services from this limited network. You're doing this also because in some cases you have no choice, because your economics allow you only a much cheaper premium. Or honestly, you're doing it because nobody told you you have option one. That you're confronted, and believe me, your mailbox will attest to this, with dozens, hundreds of solicitations for you to buy an HMO or a PPO from UPMC or Highmark, or pick any of the companies. And why would they rather you buy that than a gap? Why would they tell you about that and not about a gap? Because those companies, if they can talk you into getting an HMO or a PPO product, are reimbursed by the federal government a lot. Medicare, remember, is not going to be covering you at that point. They're not responsible for the healthcare needs. This is exclusively up to the HMO or PPO to handle that. And to do that, they encourage HMOs and PPOs to aggressively try to enroll the individuals. And to do that, they subsidize the HMO and PPO companies to the tune of about $1,200 to $1,500 a month. If I, UPMC or Highmark or Aetna or Cigna, pick any company, can get you to take my option 2 rather than getting a Medigap, I know no matter what premium I'm going to collect, I'm going to be getting at least $1,200 to $1,500 a month on top of it, thanks to the government, because there is a mutual desire to move you from the government-based to the private-based insurance. And I'll embrace those limitations, saying, but look at what I'm saving in premiums and maybe some other things. Maybe it's the free dental they're giving me and the free eye care and that health club membership. And oh, these are cool things. And oh, they'll even roll the Part D into it at no additional premium. And it looks great. And I really love the fact I'm not paying much. But keep in mind, it's a value judgment. Do I want the quality of the promise that it will be there and cannot be taken away or modified? Do I want the promise that it will cover the entire cost of my care? Do I want the promise I can go essentially anywhere in America? But for that, I'm going to pay a premium, typically with a Medigap of about $120 to $150 a month, plus the premium of the Part D, which could be whatever it is, versus a much lower premium, but willing to accept the limitations. And there's nothing wrong with that. I'm a healthy 65. I'm seeing the doctor a couple times a year and I'm not taking any meds or they're all generic. Why do I want to shell out even an extra $150 or $60 if I don't have to? Well, maybe I'll get the option 2, then shift to option 1. No. That choice, option 1, option 2, is going to be made during the first 6 months of you entering Medicare. During those first 6 months, specifically when you've enrolled in Part A and Part B, you can pick whatever you want, any Medigap, and they have to sell it to you, no underwriting. You have a guaranteed access to the product. After the 6 months are up, if you want a Medigap, then you must go through underwriting. And chances are by that point where you want it, because there's an economic need for having it, you're going to be turned down because of an existing health condition. Now, there's some exceptions. They're called triggering events. We'll go through them individually with you, but essentially there's about a dozen or so of them. And the common denominator is through no fault of your own. The current coverage you have could be a option 2 type product or an option 1. It was taken from you. The company went out of business. You moved away. It doesn't cover you anymore. Or they're just dropping it. Well, that's a triggering event, and that would give you a right to get any additional product, and that could be a Medigap. There's no guarantee. In fact, there's a very slim guarantee that that's going to happen during your lifetime. So it's more likely that your access to the Medigaps 6 months after that. Hope you like option 2. This simply gives you an idea of the extent of what the Medigaps look like. You'll notice the columns that have the most checks are the best. The best is the F. People are going to say, but you can't get the F anymore. You can if you were born before 1955. Anyone born before 1955 has a guaranteed right to any of these products as long as the company is selling them for the rest of their life. People born after 1954, 1955 on, they can have access to any of the products the company's selling except the F and the C. That's the easiest way I can describe it. This is your Part D plan, and the Part D is going to be a separate product, and simply know, in terms of its functionality, that throughout the course of the utilization of that product, you are going to be paying initially a cost share with the insurance company, typically a 75-25 split, until you've spent a significant portion on the cost of the drugs, and currently that's about $4,100. And then The insurance company backs away. They're not covering you any longer. You're in what's called the coverage gap, or the donut hole. And you stay in the donut hole until you, out of your own pocket, have purchased your prescription medications up to a certain amount, and that amount is just a bit more than $6,500. Ouch. Then, once you reach that, the insurance company comes back online and you're responsible. Now, last thing to make the point, there is assistance while you're in the donut hole. It isn't based on income, it's simply based on once you're in the donut hole, the federal government will step in and assist you to the point of 75% of the cost of the drugs, kind of balancing out the impact of the coverage gap. So as long as that stays in effect, and there's no guarantee it will, but as long as it stays in effect, it mitigates to a great deal the impact of the coverage. At this point, if there's any time left and you guys have any questions, I'll be more than happy. If we don't get to it, or if you think of questions down the road, on the very first slide of this presentation is my contact information. It's the office number, and it's also my email address. If you email me, let me know that you have a question. Give me a contact number. We'll set up an appointment and talk about your particular situation. Beyond that, thank you for attending. Questions?
Hi, Bill. That was fantastic. I think a lot of people have been getting a number of messages saying how informative they thought it was, and so definitely thank you for that. One of the questions that we received was regarding enrollment. Is it possible to begin the enrollment process any earlier than the 3-month window?
No, they will actually not take the application, or what they will do is basically stick it in a waiting box. That is the last thing you want, because they may forget to take it out of the waiting box. Unfortunately, the earliest you can do this is if you're doing this based on an entry point at 65, the 3 months leading up to that. If you are delaying enrollment, you can start ramping up the process months and months and months ahead, even more than 3 months. And that is reaching out to the employer and saying, this is what I'm thinking about terminating. This is what I'm thinking about shifting from the employer-based product to Medicare. I need to make sure you're going to produce the L564 for me. Good, I'm happy, and put it in a PDF file so I can attach it properly. And you can start shopping for the kinds of products you want. But keep in mind, you can't enroll in them until you have Medicare A and B in place, or the promise it's in place, and your card identification number. But you can do all this ahead of work. And I've often worked with clients 5-6 months ahead of time, getting the groundwork so that when they're finally ready, it's a pretty smooth process. But the actual step of submitting, at that point, you're going to be looking at usually, again, 2 to 3 months out from when that date's going to occur. And that's about as early and as much running time as you can give yourself.
Okay, excellent. Another question. You mentioned that 8 months relating to having continuing coverage from an employer.
Mhm.
Does that mean that you have 8 months after your employer coverage ends to sign up, or that you can start signing up 8 months before your employer's coverage runs out?
It's the first one. From the date of the termination of your employer benefit, you're granted an 8-month gap of time to resolve all the issues necessary to get your Medicare Part A and Part B. The reason you might use the 8 months is, for whatever reason, that employer health benefit is incredible. And honestly, where it's incredible is it covers your drugs that are going to be hugely expensive, so much better than Medicare's Part D ever would. And you want that coverage so badly, and the employer says, I know, but I can't keep you. I'm going to have to lay you off. God, I need this for the drugs that I'm taking. And the employer says, you can always COBRA this benefit. Yes, I could. I'm going to pay, but you know what? The cost of my drugs are way more expensive than the cost of the COBRA to maintain my employer plan post my termination. Now, I could COBRA for 18 months. As I know you can't. If you're already eligible for Medicare, you can COBRA until you must enter Medicare without facing a penalty. That's 8 months. And this is where the goof occurs. People assume that COBRA-ing an employer benefit means continuing the employer benefit. And then once the COBRA is done, hey, now I'm entering Medicare. You're entering it late. You had 8 months, not the maximum time for COBRA, because COBRA is not counted by Medicare as employer benefit coverage. It's a post-employment benefit, call it whatever you want. It ain't employer coverage, and therefore 8 months is all you get.
Okay, excellent. Another question. Would you recommend enrolling 3 months before your 65th birthday instead of waiting to be automatically enrolled?
Well, if you are going to be automatically enrolled because you're already collecting Social Security, you're going to be told by the Social Security Administration, if you can even manage to talk to somebody under these current situations, that no, you don't have to do anything. We're going to do it for you. Please, I'd really rather. It's like, but we can't take your application because it's not going to be done until we decide to do it. Now, at least you can determine, am I in your system? Am I on your radar? Absolutely. We know that you're collecting Social Security. We know because of your disability or because of your age, you are going to be going into Medicare. We know this is going to be computer generated. There's not a human being that's in an office that has to take this responsibility. It is going to be spit out. And the computer is automatically going to be tracking you to put you into Medicare. This is the one time you don't have to worry about the screw up. This is likely going to be a fire and forget simply because you're in their system, you're on their radar.
Okay. Does the Railroad Retirement Board Medicare cover something different than Social Security Medicare?
No, if we're talking about railroad retirement versus Social Security, that's simply a portal that gets you into the system. Railroad retirement is simply just an office that you go to say, I want to enroll in Medicare A and B, as an alternative to Social Security office saying, I want to enroll in Medicare A and B. Either of those are putting you into Medicare. That is a third entity. It is separate from Social Security. It is separate from railroad retirement. It is simply Medicare Part A and Part B, which now gives you the entitlement to go and buy private insurance. Railroad retirement does not define your Medicare benefit. Social Security does not define your Medicare benefit. They simply define the process of enrolling in it.
Okay, I think you touched on this, but just as a follow-up to that, if you have a supplement plan, does the Railroad Retirement Medicare cover anything that the supplement doesn't cover?
Well, the railroad retirement, remember, and again, I want to emphasize this. You're thinking of railroad retirement as a healthcare benefit. Now, possibly the place where you worked as a railroad employee may offer you its own employer benefit package. Think back to this slide. And the first drop down, you have Medicare A and B, which is identical to whether you go to the Social Security office or railroad retirement and say, I want Medicare. Your Medicare A and B is identical. Now, your employer, which happens to be a railroad company, Chessie, B&O, whatever, says, oh, we got this really cool retirement benefit. And guess what? It's a supplement. And it works really kick-ass good. That is their benefit. Just happens to be in the form of a supplement, and it may be excellent. Will it be exactly like a Medigap? Very likely. Will it be different? Could be, because it's an employer benefit, not truly a private insurance Medigap. So if it's a true supplement, as in Medicare A and B comes first, Medicare A and B is always going to be identical no matter whether you got it as a railroad employee or any other kind of employee. It's what you're going to supplement it with, and that's going to depend on the employer, the benefit the employer is offering, and how much it looks like a regular typical Medigap. I can tell you that the types of Medigaps A through N are very definitive. When you go to an insurance company and say, what kinds of Medigaps are you selling? Well, I've got the A and the C and the F and the G. And it's like, what's it like compared to the other? They're identical by law, at least in Pennsylvania. Any company that's selling one of those levels of Medigap, A, B, C, D, F, G, etc., they must be by law identical. What they cover has to be exactly the same, no matter what company you're buying them from. So what's the difference? The premium and how the premiums go up from company to company. The only variable is the cost that they charge. But an employer supplement may not adhere to A, B, C, D, F, G, etc. They could create their own whole spectrum of coverage. It's secondary to Medicare A and B, but it cannot guarantee it's going to be exactly like those. And that's the issue. Often a person, and I'll give you an example, people that work for the University of Pittsburgh, and that includes UPJ as well, are going to say, oh, my employer's offering me a supplement. Is it a Medigap? And I'll say, not necessarily the same. It's going to work as a secondary benefit. It's going to look pretty good. Let's line it up. Let's look at what it promises to cover and see which of these categories it's come closest to. And let's see how much it costs. And surprisingly, and I'll use UPJ as an example, PIT in general, I find that their supplements very much look like AF, very comprehensive, very good, but they cost about 3 times as much as if you went out into the market and found one on your own. So I won't go into it in detail, but it's usually a best practice to compare what the employer is offering you as a retirement benefit or even while you're employed, and seeing if it really is superior to what you could get in Medicare in cost and in coverage. It's worth a look. Go ahead.
All right. Once you are in what you term as the donut hole,
Yes.
who do you contact to help get you the help that you mentioned?
Well, you don't have to. It's an automatic presumption. So imagine, okay, you have Part D coverage, and here I'll give you an example. So you're taking a particular drug. It is expensive as hell. That drug, and I'm going to give you an example, is Humira. And you take it because you'd like to walk occasionally. And that drug costs retail about $5,000 a month. So you're going to show up the first month and you're going to say, hey, plan at the pharmacy, I need to get my month's supply of Humira. Now at that point, there's going to be a split. 75% of the cost of the drug is paid for by the plan and 25% by you. But you know what? In that context, you've already spent $4,130 just for that 1 month supply and then some. You're in the donut hole already, first month. And I promise you, by the second month, you're going to be out of the donut hole. You will have spent out that additional $6,550. But while you're there, oh my God, do I have to pay the full price of this $5,000? No. The pharmacist says, let me put in at my point of sale register, your cash registers are now glorified computers. You know what? Congratulations. The federal government just kicked in. They're covering the 75% that the insurance company normally would do. You're still paying essentially the 25%. And here's the point. And I'm using this example to drive this point home. Start with the presumption Part D is terrible. It will never be an effective coverage for your drugs the way it's set up. You will be stuck, even in the best of circumstances, paying a buttload of money. Now, you could exacerbate that by saying, oh my God, let me get the best Part D I can find. Let me get one that's hundreds and hundreds of dollars a month. Except, it doesn't matter what that plan promises it's going to do. If you have one or more drugs that are so expensive, it's going to pump you into the donut hole in the first month or two, the plan's promise is irrelevant. The plan will only do a split with you, and they may do better than 75-25. They may promise you the moon for a higher premium. We'll do 90-10 for you. Wow! Except till you get into the donut hole, until you said, I want my Humira. And they'll say, oh, you know, the first month it's free. They'll even pay the entire amount for you until you hit $4,130. How much does the Humira really cost? $5,000. The insurance company says, we just shelled out $5,000 for you. We're done. We spent way more than the $4,130 we had to. We're done. Till when? Till you buy enough drugs to dig yourself out, that metaphor, of the donut hole. You're already in a hole. Oh my God, I've got to spend $6,500. Not our problem. The government automatically steps in. How do they know? Because they're tracking your purchase of drugs through the pharmacy. The pharmacy's point of sale register is connected literally to the insurance company's plans and to the federal government Medicare system. For them to be able to sell prescriptions under the Medicare system, they must have unique computer-driven cash registers that information is automatically real-time transferred not just to insurance companies, but to the Medicare system. They could tell you on the turn of a dime when you've gone into the donut hole and when they're responsible for covering the cost now because the insurance company's offline, and when they're done with you because you've gotten yourself out of the donut hole. And when you're out of the donut hole, the insurance company comes back online and they're required to split the cost at 95.5. So the plan that you're spending $200, $300, $400 in premium, oh, please God help me. Keep this in mind. Whatever promises they make are only good until you go into the donut hole. Then they're done with you until you've dug your way out of the donut hole with the help of the federal government, and they're not going to help you. And when they come back online, they must come back online in the catastrophic coverage. No promises have to be made. They're going to do a 95-5 split. Here is what I find over and over again. A cheap premium Part D works quite nicely if you're taking hugely expensive drugs, because no matter what the higher premium is going to promise, the promise is only good till you hit the donut hole. After that, federal government takes over, and after that, the insurance company comes back online, but they don't get to choose how they're covering. It's a 95 split. That's it. Till the year's over and we start the cycle again. I find over and over for individuals that are in high-end cost drugs, ironically, a less expensive Part D product works much better because at least instead of where's my $300 a month premium, it's where's my $10 a month premium. And the difference in coverage after you hit the donut hole is the same. There is no difference. Next question.
All right. So when someone starts hospice on the supplement, say UPMC, are you allowed to choose Medicare hospice coverage, I assume, instead?
Well, first of all, UPMC doesn't sell supplements. So it must be an HMO or a PPO you're talking about. And depends. If you're using them to pay, no, you have to stick with their network. If you go offline with UPMC and say, I'm not going to use you guys, and this is the one exception where if you have an HMO or PPO, you can literally say, you know what, I am going to rely on hospice care outside of my UPMC or Highmark or any other company's coverage. I'm going to rely instead directly on Part A, and Part A will say, we're good. And the more to the point, hospice will say, we're going to bill Part A directly. And they're going to possibly encourage you, this is under Part A and you don't need to even use your UPMC. Don't give it up. You may be switching back and forth between hospice and non-hospice care during the remainder of your lifetime. But if you're going to try to get any kind of level of care in tandem with hospice, or if you try to use your HMO or PPO to cover costs associated with your declining health, you're going to be limited to where you can go. And it's more the point, since we brought this up, forget hospice just for a second. And let me show you a different approach. Why having Medicare as your primary coverage is way better than an HMO or PPO. So it's not hospice. What you need is home-based care. You're unable to leave the house. You're unable to navigate through the community very well. And the kind of care you need is being brought to your home. And a good example is you are a quadriplegic. Getting out of the house is difficult at best, impossible most likely. And so the kind of care needs to be brought to you in your house. And one of the pieces of care you need is equipment so you can breathe. You cannot breathe on your own. Now, you need people to come to your house regularly to make sure that equipment is working. You need to have people coming to your house to make sure the other kinds of services are being administered. This is not personal care. This is not feeding you, toileting you. This is medical care. And if you don't get it, you will die, and not in a very nice way. You want the best you can get. You want people that you can rely on as being quality caregivers. If you're relying on an HMO or PPO, you get what they give you. And if you don't like them, tough. And if it's the pandemic, I'm sorry, we can't send anyone to your house. We don't have anyone that will do it. But I'm going to die. I know it's a shame. You probably should go into a nursing home. I use that not as a hypothetical. I've had several clients that, because of significant health issues, required health care at home. But because insurance companies said, I'm sorry, force majeure, can't get people to come. What am I supposed to do? It's probably best to institutionalize the person. And two of the clients that did that died from COVID. They'd be alive now. They hadn't got into the long-term care institutions, exposed to the COVID virus. They'd stayed home. They couldn't stay home because the equipment they needed and the service they needed weren't being delivered by that HMO that said, these are the entities we work with and you have to stay within this. Medicare allows you to go shopping. Do you take Medicare? Yes. Do you take Medicare? Do you take Medicare? Yes. Can you send people to my house? Absolutely. And how are we going to pay the balance? My Medigap. The people that have Medicare and a Medigap have a greater reach of services. Those people were able to maintain home health care much better than people that are relying on HMOs and PPOs. Have I scared you sufficiently? Next, Drew.
All right. The next question that we have, if I received my letter stating that I'm not eligible until age of 66 and a half for Social Security,
Sure.
do the same rules apply for benefits at age 65, the 3 months before and 4 months after?
Well, we're talking apples and oranges now. So we're talking, I'm not going to be eligible for Social Security till I'm 66 and a half. That's understandable, but it has nothing to do with Medicare. Nothing to do at all with Medicare. When am I eligible for Medicare? When you're 65. What are my 3 months leading up to it? The 3 months before the month you turn 65. And the only issue is, how are you going to pay for your Part D? Well, I'm not collecting Social Security, so you work out an arrangement with the Social Security Administration to pay. Social Security benefits and Medicare benefits are completely separate, and the eligibility criteria are now completely separate, and the process of entry is also completely separate. There is no intersection.
All right, and I believe this is our final question here. If a spouse is on my healthcare coverage and is collecting Social Security, when my spouse turns 65 and is enrolled in Medicare, can they stay on my healthcare coverage, or do we need to purchase either a Medigap or a Medicare supplement plan?
Well, it depends. Go back to what I said before. Is the employer a large employer or a small employer? If the employer is a small employer, as much as you may want to hold on to it, the employer benefit, I mean, you may be summarily booted out. If it's a large employer, so me, I'm still working. I have a spouse that's on my employer benefit. She's turning 65. She says, I'm going to enroll in Part A and Part B. And it's a large employer. What's the dynamics? Well, my employer plan will continue to be my primary coverage and her primary coverage. And the Medicare, the Part A, the Part B, or just the Part A, if that's what we choose, will be secondary. It will help out. Reverse that. I do work for a small employer, okay? So I'm going to enroll, she's going to enroll in Medicare A and B. Now for me, my employer benefit, small employer, I'm not 65 yet, so it's going to be my only coverage. For her, that benefit will now become secondary. So we're going to have this kind of weird bifurcation, not of the benefit, but of the coverage. And here's the problem. Guys that set up these plans for employers, I mean brokers, sellers of insurance products, do not always adequately prep the people for understanding this transition. I can give you plenty of examples of where the person's found out too late when they should or shouldn't do, nor how this is going to coordinate well with Medicare. And they could do these kind of strategies for effective utilization. So it is worth, first of all, as you start approaching 65, or your spouse starts approaching 65, to aggressively reach out to the company, not the guy who set you up, and honestly, not even basic customer service, but someone representing that employer benefit. And you know what they're going to say? Check with your HR. I am the HR. I don't know what's supposed to happen. Oh, and find out what the mechanics are. And often they're going to say, well, read your contract. This is what it comes down to often. And see if this is a doable thing. And honestly, within the general rules, yeah, it's doable. But that's when you want to start determining, is it even worth it? Maybe I don't want my employer benefit to be secondary and the cost of it. If I just go with me covered, we actually save enough money that 120 I'm saving or 150 I'm saving by me going off is more than adequate for her to get a good Medigap, and the coverage is perfect, or at least close to perfect. So that's worth considering.
All right. Well, that wraps up the content questions, Bill. I mean, this was a fantastic, fantastically received session and a fantastic amount of information. And we can't thank you enough for being here to explain all of this.
Let me
for
recommend
us.
this, two or three things, just real quick.
Sure.
Again, if you have questions or issues, you've got at the top of the slideshow and at the bottom of the slideshow my contact information. If you are interested in having other presentations that talk about specific things like Part D in more detail, or about the pitfalls in navigating through the entry point into Medicare and going to more depth, I'll be more than happy to come back and do other hour sessions with you guys and answer your questions and help you figure things out. That's what we do. That's our job. That's the task of Pennsylvania Health Benefits Support Program, to help you guys in the community make good choices. So stay safe, stay sane. See you guys later.